So let's look at another case here. This is about a 35-year-old female patient, and you can see more of a triangular tooth form, which is known to be very challenging, thin biotype, external resorption. So we extract the tooth. We're going to graft both with the lid, bone, and the crepe graft. And in this situation, what I've done is the most superior suture you can see is holding the crepe graft in place, but I've also done a lid graft and wrapped it all the way up the facial and to the palate. And the attempt here is to keep the bulk or increase the bulk in that very thin gingival margin, almost translucent if you look at the tooth number, if you look at number 9. So can we maintain, increase this area? Flipper is in place, and again, I try to design my flippers with what I think will be my final crown form. So 10 or so days down the road, you can already see we're maintaining our papillas and maintaining our gingival architecture. Again, in this case, we really cut back our ovate flipper on the ovate area, almost just sock or seat right in that area. So we have a good tissue fill, and we can continue to mold and develop the tissue. So now we're at the the abutment phase, where we've taken our fixture level impression. And here you see what we're actually doing in this case is taking the zirconia on the mesial aspect and moving it more coronally to support that tissue. Not to squeeze it out, but to help to support that very long papilla in that area. Now, the technique that my restorative dentist lab technician used was to do a pattern and then have the zirconia cut in one of the milling machines, and then put an additional core over top to help with the color match. So here's that in place. You can see we still have maintained our papilla, both mesial and distal. If you look at the difference in the heights of the zirconia on the distal versus the zirconia on the mesial, and there's our final result. Acceptable. Maintained our papillas both in the midline, smile view. Okay, so here's another case where we have a 45-year-old male, and he has a thin biotype. And normally, in my experience, in male patients, we traditionally have a more thicker biotype. However, in this situation, triangular teeth, thin biotype, more apical margin on tooth number 8. So go ahead and atraumatically extract the tooth, buccal gap in place. Go ahead and graft this with both our lid and crepe technique. Flipper, molding the tissue. And you can see that we're already starting to bring that tissue more coronal. And once we remove it, you can see we've got nice bulk maintaining our papillas. There's our healing abutment in place, and you can appreciate the volume of keratinized tissue in this area, as well as at the sulcular margin, the free gingival margin, we have the nice, what I like to call sausage roll effect that we find on the adjacent tooth. So our zirconia abutment, and in this case, again, you see where we're supporting the papillas but not squeezing them out. Now, I had previously mentioned the technique of utilizing the provisionals to help to shape the tissue. So what will be done here is at that cervical margin now, we'll take a burr and thin that out and make it more concave prior to placing it in the mouth. So our lab fabricated provisional at the day of insertion, and you can see it's blanching, and that will go away within 10 or so minutes. Just a little close-up. Again, we're approximately 2 weeks after this has been in place, and we're actually been able to fill our papilla in. And here's our final crown. Well, what about when we have adjacent centrals? Are we able to achieve similar success? Can we do our technique that we've done on the single tooth? Well, let's look at a few cases. So here you see a patient, and I've left the mustache here in this case on purpose to show you that this is all the same patient. This patient presented to me initially at fractured tooth number 9. I subsequently extracted. He has a very thick biotype and placed his implant. He has a crown on tooth number 8 that we asked the patient, would you like to change this crown so that we can match both your teeth at the time of restoration? And he really had no interest in doing that. So on Halloween of that year, he walks back into my office. We're still working on number 9, and he had fractured tooth number 8. So he said, well, I guess you'll get your wish, and we can restore both teeth. So again, a traumatic extraction utilizing one of my earlier lid graft techniques, allowing it to heal, and coming back and restoring both teeth. So here we're, prior to, I'm showing how we're developing our pontic development on the original number 9. And now we're going to go and work on both teeth. So we've done our grafts, we're healed. Here's a lab provisional technique. And again, we have our zirconia abutments, and in this case, our abutments are slightly narrower. But again, we're maintaining the nice bulk. You can see the degree of keratinized tissue. And so this is a day that I put in the abutments and the provisionals. And you can see on the number 8, you see some show of the zirconia abutment. The margin appears more apical. We have black triangles, both distally and mesially. And at this point I said, well, you know what? We've tapered our provisionals. Let's just let the case sit for a few weeks. So 3 weeks later, the patient returns. We had complete fill. And what I like to do here is go back and thin out the interproximal area or narrow the interproximal directly between 8 and 9 to get more papilla fill when I have a nice thick biotype like this that is very responsive to management. And just removing one of the provisionals showing how our tissue is shaping, and that we do have, if you follow our papilla from the buccal back to the palate, we do have complete papilla. At times you'll see where you'll have a longer palatal papilla than you do a buccal papilla, but in this situation we have complete fill. I lost a patient after this point, so we do not have final photos. Let's look at another interesting case. This is a 20-year-old female that I treated initially maybe when she was probably 14 or 15 years old, had traumatic injury to the anterior teeth. At age 14 or 15, I removed her wisdom teeth. She had already been through a softball accident where she injured teeth numbers 8 and 9, had them put back in, wired in. But you can see now what we're developing is on the distal aspect of tooth number 9, we have apical migration of the tissue. We've had fistula formation, which I've treated, for several weeks with antibiotics, attempting to maintain as much tissue as we can. But both these teeth were also undergoing external resorption, and it had to be extracted. Now, she was a college student at the time, and I felt that because of her travels, we had very limited time or attempts to restore her. So the decision was made along with the patient to atraumatically extract the teeth and attempt to place the implants if possible. So atraumatic extraction, we're being able to maintain the alveolar housing. We've done immediate implant placement. We'll do our lid and our crepe grafts. And if you'll notice the distal buccal aspect where we had the root surface showing in the apical migration, I've actually done a secondary lid graft to this area. So I actually had our normal lid graft, I've done a secondary crepe graft to the area. So we have our normal lid graft, crepe graft directly at the free gingival margin, and then I took another graft and folded it and tucked it up along that buccal path, attempting to try to correct where she had the tissue loss. So you can see this is showing you the technique when we use two crepe grafts in the buccal area. So immediate post-op flipper, that is a flipper in place, and I'll cut back the interproximal junction between 8 and 9 over time. We're looking at about 6 weeks down the road. Tissue still looks a little angry, but if you look at the distal buccal aspect, we've essentially corrected that for now. These were our zirconia abutments that were utilized. And this is 3 to 4 months down the road. You can see the starting of the discoloration of the acrylic provisionals, but we've almost filled in that complete area where we had our large defect. That's a little bit of immature tissue that should fill in. And again, being a college student after this, I lost her to follow-up. Well, let's look at our final case. Again, another interesting case. This is a 35-year-old lady at the time that initially presented to me when she was around 30. I had done some other surgical work on her, and at the time she told me that she had injured the teeth as a kid, had root canals, and this, I believe, were probably her 4th or 5th set of crowns that essentially kept falling off. And again, we're undergoing external resorption. But what makes this case more complicated is that now the patient is on Coumadin, and so that's a medical issue that we had to manage. So again, unequal tissue heights, width of the teeth are not the same. So we have the issue of the teeth as well as the medical history. So I consulted with her physicians, and the decision was made to go ahead and monitor and stop the Coumadin and go ahead and do immediate placement if possible. Extraction of the teeth, maintaining the alveolar housing. Implant placement towards the palate. And again, looking at our interproximal distance between the two implants, you can see I tend to place these implants probably a little bit wider than the advocated 4 to 4.5 millimeters that is well documented in the literature. So again, one of the earlier lid grafts and crepe grafts, the ovate flipper in place. Again, what's important here is if you look at the extrusion of the graft at the keratinized free gingival margin there, I'm attempting to bring this more coronal or giving me what I like to call narrowing down the sulcus, so then I can push it back both mesially and distally to help to support and create the papillas. So a couple of weeks out, now we're at about 8 to 10 weeks, and a couple of things that you'll notice here: completely keratinized, acceptable sulcular shape and form, and the tissue is not as erythematous as prior to extractions. So now I'm just going to use a minimally invasive technique, punch out the cover screws, take my fixture level impressions as you see here, and even in the impression copings you can see the spacing. Zirconia abutments, again, very careful not to squeeze out that midline papilla. Lab fabricated provisionals, and I like, at times you'll see where there is some soft tissue on the stone cast, but I do prefer a straight to the stone molding of the provisionals. So this is the day we put them in, blanching of the tissue, 6 months. And that was 6 months because it was difficult for me to get the patient back in, but that papilla filled in within 2 to 3 weeks. Final crowns. And one of the things that I like to look at when my restorative folks fabricate these crowns, I like to look at the palatal or the lingual aspect and look at the contour of these crowns. Now, if you look at the contour next to the natural laterals and canines, you know, these are well contoured. And probably my favorite slide of all, if you magnify this slide and look at the implant placement, look at the interproximal bone between 8 and 9, you can almost see the bone. Look at the abutment interface and the bone going all the way up to almost touching the contact point of these crowns, as well as if you look at the distal aspect of number 8, you can see, you know, we've been able to maintain our bone and as a result maintain our soft tissue. I would like to thank Dental XP for giving me this opportunity, and this is Dr. Richard Martin. Thank you very much.